Imagine putting high-performance Formula One brakes on a well on a heavy daily commuter car.
Right. They would just burn out.
Exactly. I mean, they will stop that vehicle brilliantly for a week. You get this incredibly tight, responsive feel.
Oh, absolutely.
But under the sheer, unrelenting load of heavy daily driving, those highly engineered components are going to completely disintegrate.
Yeah, they really are.
And that is exactly the biomechanical gamble you are taking every single time you implant a highly constrained reverse total shoulder arthroplasty into, say, a 54-year-old manual laborer.
It is a massive gamble.
It is. If you are a mid-senior orthopedic surgeon listening to this deep dive, you already know the landscape of shoulder reconstruction has shifted completely beneath your feet.
Oh, without a doubt.
We are no longer reserving this procedure for the frail 80-year-old patient with cuff tear arthropathy who simply wants to lift a cup of tea to their mouth.
Right, the classic Graham indication.
Exactly. We are putting these mechanical constructs into younger, highly active, high-demand patients. And by doing so, we are fundamentally changing the rules of joint survival.
We really are.
So the mission of our discussion today is to strip away the marketing and look at the hard physical realities of what happens when you push this technology to its absolute limits.
And it is a critical examination that we desperately need right now. I mean, when you look at the original design conceptualized by Paul Graham back in the 1980s.
Which is brilliant for its time.
Right, it was absolute genius. But the entire biomechanical philosophy was based on salvage.
Right.
The brilliance of Graham's design was medializing the center of rotation and lowering the humerus to recruit the deltoid.
Right, artificially increasing its moment arm.
Exactly. You increase the moment arm to compensate for a massively deficient rotator cuff. But it was a low-demand solution for a low-demand problem.
That makes sense.
By deliberately altering the native kinematics by creating this semi-constrained, non-anatomical joint, you inevitably introduce new stress risers.
Right, especially on the glenoid side.
Exactly. The bone implant interface is subjected to shear forces that a native joint simply never experiences.
Never.
So when you take that salvage biomechanics and apply it to a 55-year-old who expects to return to construction work.
Or heavy lifting in the gym.
Yeah, exactly.
Yeah.
You're basically setting a timer on a complex mechanical system. We have to ask, are we securing immediate, undeniably impressive kinematic victories at the cost of catastrophic long-term mechanical failures?
And that is the exact question we are going to dissect today. We are going to critically examine the reality of performing this procedure in that younger, high-demand patient cohort.
We really need to dig into the specific complication profiles there.
Yes, exactly. We will explore the inevitable looming revision burden that follows, specifically breaking down the brutal mechanics of rescuing failed anatomic and hemiarthroplasties.
Which is becoming a huge part of our practice.
It is. And then we will deliver a masterclass in managing the structural nightmare of severe glenoid bone loss.
Right, moving beyond just the simple metrics.
Exactly, getting into the cellular and structural physics of bone grafting versus augmented base plates. And finally, we will scrutinize the digital frontier.
Ah, yes, the technology debate.
The big one. If you are relying on 3D planning, patient-specific instrumentation, or robotics, we need to ask, do these incredibly expensive technologies actually improve implant survivorship?
Or do they merely improve the appearance of your post-operative radiograms?
Right, exactly. So to understand the trajectory of where this field is heading, we have to start by looking at the patients sitting in your waiting room.
And the demographics have shifted so rapidly that the exception has really become the rule.
It has.
If we were implanting these devices into a demographic that has a life expectancy of another 30 to 40 years, we need a clear-eyed view of what the current evidence actually tells us.
Right, regarding their outcomes, their specific modes of failure, and the unique biological challenges they present on the operating table.
Absolutely.
The shifting demographics are stark. I mean, if you have been in practice for more than a decade, you have felt this change anecdotally.
Oh, you see it every week in clinic.
But recent literature actually puts definitive numbers to that feeling. When we look at database findings published in 2025, analyzing the United States' premier healthcare database,
The trend is just undeniable.
it really is. In patients under the age of 60, the utilization of the reverse total shoulder arthroplasty increased from roughly 48% of all shoulder arthroplasties in 2016
Right.
to nearly 59% by the end of 2020.
Which is a staggering market penetration over a really short period.
It has aggressively overtaken the anatomic total shoulder as the dominant procedure for this younger cohort.
It has, and it reflects a growing confidence among surgeons, certainly.
Mm.
But it also reflects a broadening of surgical indications that warrants intense scrutiny.
Right. We need to look at the medium-term clinical outcomes to understand the clinical reality behind those population-level numbers.
Exactly. There is a highly detailed recent series that evaluated 94 shoulders in patients aged 60 and younger.
And the mean age was exactly 54.8 years, right?
Yes, 54.8. And the breakdown of indications in this cohort perfectly demonstrates how far we've strayed from Granite's original intent.
Right, because they weren't all just cuff tear arthropathy.
Not at all. I mean, while 56% had that classic indication, a full 15% had massive, irreparable cuff tears without any significant glenohumeral arthritis.
Wow.
11% were suffering from inflammatory arthropathies, and the remainder presented with highly complex proximal humerus fracture non-unions and malunions.
Now, if you are reading that published series, the immediate successes in this younger cohort jump right off the page.
Oh, they're undeniably impressive.
They are. The published data demonstrates massive, life-altering improvements in functional range of motion.
Right.
Active forward elevation improved from a preoperative average of a miserable 88 degrees.
To an impressive 135 degrees postoperatively.
Yes, and pain relief was equally profound. Visual analog scale scores dropped from a severe 7.1 down to just 1.4.
It is entirely understandable why patient satisfaction sits at an exceptional 95%.
Right, because we are taking patients who are in the prime of their working lives, who cannot sleep, who cannot lift their arm above their chest.
And we are giving them their lives back. It is the seductive power of the reverse shoulder.
It really is. Those functional gains represent an immediate rescue for a 54-year-old patient.
Exactly. The ability to restore forward elevation simply by recruiting the deltoid is a biomechanical triumph. But, yes, as surgeons, we cannot afford to be blinded by the short-term functional scores. We have to balance those triumphs against the reality check provided by the complication data.
Which tells a much more sobering story.
It really does.
Yeah.
In that exact same medium-term study of 94 shoulders, the overall complication rate was 12%.
12%. And the hard reoperation rate.
A 7% hard reoperation rate. Furthermore, when we return to the matched cohort analysis from the 2025 database findings.
Right, the broader population data.
Yes. The data reveals a 1.53 times greater odds of 90-day surgical complications in the under 60 group compared to matched patients over the age of 60.
See, that is a statistic that should make every surgeon pause. We are seeing a 50% higher risk of early surgical complications simply by virtue of the patient being younger.
Exactly.
You are operating on a 55-year-old, and despite them likely having fewer systemic comorbidities, like advanced cardiovascular disease or severe diabetes compared to an 80-year-old.
Their shoulder is significantly more likely to fail early.
Right. And I want to drill down into exactly why that happens. Is this primarily a biological phenomenon occurring at the cellular level, or is it driven by patient behavior and mechanical overload?
Well, it is a volatile collision both, actually.
Yeah.
And you have to understand the interplay to manage these patients effectively.
Okay, I'll start with the biology.
Right. Biologically, the younger patient mounts a vastly more vigorous inflammatory and fibrotic response to surgical trauma.
They heal almost too aggressively.
Exactly. When you enter a 55-year-old joint, the capsule is thicker, the vascularity is more robust, and the subsequent scar tissue formation is significantly more aggressive.
Which leads to stiffness.
Yes. This leads to early stiffness, which puts immense stress on the implant interfaces during rehabilitation.
Right, because they are fighting their own scar tissue to move the arm.
Precisely. Furthermore, look at the pathology we are treating. In an 80-year-old, you are typically dealing with a primary degenerative wear pattern.
The bone is soft, but the anatomy is at least predictable.
Right. But in the younger cohort, we are frequently dealing with post-traumatic fracture sequelae. You are navigating through heavily scarred tissue beds, distorted tuberosities.
Altered axillary nerve anatomy?
Yes, and compromised bone stock from the initial trauma. The sheer surgical complexity is inherently higher, which obviously drives up the intraoperative and early post-operative complication rates.
But wait, even if we assume the surgery goes perfectly, you navigate that scarred tissue bed flawlessly. The behavioral aspect seems to be the absolute elephant in the room.
Oh, it absolutely is.
An 85-year-old patient is generally content to adhere strictly to your postoperative lifting restrictions, right? Because their baseline demands are incredibly low.
They want to knit, they want to read, they want to get dressed.
Exactly. But a 54-year-old construction worker or heavy mechanic, they feel mechanically sound 3 months after surgery.
Their pain is gone, their deltoid is strong.
And they immediately want to return to their baseline activities.
And that behavioral drive is exactly what accelerates mechanical failure. This directly correlates with the current evidence on occupational physical demand.
What does the data show there?
The literature clearly demonstrates that patients engaging in heavy or very heavy manual work report significantly less improvement in their postoperative pain scores.
Really? Why is that?
Because they are mechanically overloading a highly constrained non-anatomic system. When a manual laborer lifts a heavy load away from their body, the shear forces transmitted across the glenoid base plate are immense.
Right, because the reverse design relies on a fixed center of rotation.
Exactly. It does not have the dynamic, shifting fulcrum of a native rotator cuff to absorb and distribute that load.
So every single heavy lift
Translates directly to micromotion at the base plate bone interface.
Yeah.
Over time, that micromotion prevents true osseointegration.
It leads to fibrous encapsulation.
Yes, fibrous encapsulation, osteolysis, and eventual aseptic loosening.
Wow. We also have to consider the surgical history of these younger patients because they rarely present as a virgin shoulder, do they?
Very rarely.
The published series shows that 70% of this under 60 cohort had undergone at least one prior operation on the index shoulder before finally receiving the reverse arthroplasty.
And that is perhaps the most crucial prognostic indicator you can evaluate in the clinic.
Because of the tissue damage.
Exactly. Every single prior intervention, whether it was an arthroscopic cuff repair, an open reduction internal fixation, or even just a massive subacromial decompression.
It leaves a permanent footprint.
It does. It alters the tissue planes, it compromises the vascular supply to the deltoid and the remaining cuff, and it changes the resting tension of the musculature.
Which obviously impacts the outcome.
Heavily. The published series robustly correlate a history of prior operations with significantly worse postoperative functional scores.
Specifically on the American Shoulder and Elbow Surgeons scale and the Western Ontario Osteoarthritis of the Shoulder Index, right?
Right. The more previous surgeries a patient has endured, the less predictable and the less successful their outcome with a reverse arthroplasty becomes. You are building a complex structure on deeply compromised foundations.
This brings me right back to the Formula One brakes analogy. We are offering a reverse total shoulder to a 54-year-old manual laborer with an irreparable cuff tear, knowing full well that their heavy occupation will blunt their pain relief. Knowing their fibrotic biology makes the surgery harder, and knowing their age puts them at a 50% higher risk of early surgical complications.
It is a difficult reality.
Are we actually doing them a disservice? I mean, if we know the implant will inevitably fail under their mechanical demands, shouldn't we be holding off, perhaps pushing conservative management or joint-preserving options, even if they are less effective in the short term?
Well, that is the ultimate clinical dilemma you face in your consulting room. You are forced to balance the patient's immediate, profound, and often economically devastating disability against the absolute certainty that they will outlive their implant.
Right, because if you deny a 54-year-old laborer the surgery, you're potentially condemning them to a decade of severe pain.
Exactly. Severe pain, narcotic dependency, and the inability to provide for their family. But if you proceed, you are setting a timer on a complex mechanical system.
So what is the solution?
The solution is not necessarily to deny the surgery, but to master the informed consent process. You must have incredibly frank, transparent discussions.
You have to lay it all out.
Yes, the patient must explicitly understand that this is a symptom-modifying salvage procedure, not a physiological time machine.
I love that phrasing, not a time machine.
Right. You must tell them, I can take your pain away today, but if you return to swinging a sledgehammer, I will be seeing you back in this operating theater in 5 years for a catastrophic revision.
And because they will inevitably outlive their implants, or because they are presenting to us with failed primary anatomic total shoulders or hemiarthroplasties from a decade prior, we are seeing a massive impending surge in revision procedures.
It is the inescapable mathematical reality of our shifting demographics.
Exactly, which brings us to the formidable challenge of the revision reverse total shoulder arthroplasty, a procedure that really tests the limits of both the surgeon and the technology.
The revision burden is the inevitable shadow cast by the aggressive expansion of our primary indications. To truly understand the magnitude of this challenge, we must examine the comprehensive 2024 systematic review.
The one that analyzed over 1,000 shoulder.
That's the one. Specifically, 627 anatomic total shoulder arthroplasties and 414 hemiarthroplasties that required extraction and conversion to a reverse system.
That is an enormous data set.
It is, and it provides a highly accurate reflection of real-world outcomes.
Now, the functional rescue achieved in these massive revision cases is, on paper, substantial. The data shows that the American shoulder and elbow surgeons' scores effectively doubled.
Right, jumping from a miserable preoperative 32.6 to a postoperative 61.9.
And active forward flexion also improved remarkably. It moved from roughly 59 degrees, which is essentially a pseudo-paralyzed arm, to 107 degrees.
So we are returning basic space-reaching function to severely disabled limbs.
Right. We are giving them the ability to reach a shelf or wash their hair.
We are indeed. And for a patient with a failed implant, achieving 107 degrees of elevation feels like a miracle. However, as surgeons, we must view those functional improvements strictly through the lens of the complication burden, which is, frankly, severe.
Extremely severe. In this massive revision cohort, the overall complication rate was 23.4%.
Nearly 1 in 4 patients suffered a major complication.
And the hard reoperation rate stood at 12.5%, or 1 in 8.
Think about that. You are taking a patient who has already failed one arthroplasty and subjecting them to a procedure where they have a 25% chance of a significant adverse event.
When you are sitting in clinic looking across the desk at a patient who is already traumatized by a failed surgery, how do you justify a procedure with a nearly 1 in 4 complication rate?
You justify it by ensuring the patient understands that the alternative is a flail, chronically painful extremity.
Right, but when we break down the specific complications, the patterns are incredibly revealing about the limits of our engineering.
They are. The most common complications identified were glenoid component loosening at exactly 6%,
Paraprosthetic and intraoperative scapular fractures at 4.7%.
and deep periprosthetic infections at 3.3%.
Let us deeply unpack the mechanics of those specific failures because they tell us exactly where our structural vulnerabilities lie. Why is glenoid loosening the primary mode of failure sitting at 6%?
Well, think about the physical act of extraction. When you remove a well-fixed or even a partially loose anatomic glenoid component, whether it is a cemented polyethylene peg or a metal-backed keel design.
You are never just removing the implant, are you?
Never. You are inevitably extracting vital load-bearing subchondral bone along with a cement mantle.
Right.
And in the case of a failed hemiarthroplasty, you are facing a completely different but equally devastating pathology. You have a glenoid vault that has been progressively ground away by a hard metal humeral head over several years.
Creating a massive uncontained cavitary defect.
Exactly. In both scenarios, the bone stock left behind to support your new reverse base plate is heavily compromised, severely osteopenic, and structurally deficient.
This directly limits our mechanical fixation. You are trying to anchor a highly constrained, load-bearing base plate into a structure that has the consistency of an empty eggshell.
That is a very accurate description.
We also have to address the nuances of range of motion recovery in the revision setting because it is not a uniform success story, is it?
No, it is not.
While forward flexion and abduction show reliable improvement thanks to the deltoid, internal rotation remains stubbornly, frustratingly poor.
Right.
The current evidence highlights that internal rotation often only improves from the sacrum to perhaps the 4th or 5th lumbar vertebra.
And interestingly, this minimal improvement was only statistically significant in the group revised from a hemiarthroplasty, not the anatomic total shoulder group.
Why do we consistently fail to restore internal rotation?
That limitation in internal rotation is a fundamental biomechanical constraint of the reverse design itself, and it is exacerbated by the revision environment. By medializing the center of rotation and utilizing a semi-constrained ball and socket mechanism, we inherently restrict the degrees of freedom. We are physically blocking the rotation required to reach high up the back.
The implant itself gets in the way.
Exactly. Furthermore, look at the soft tissues. Internal rotation is driven primarily by the subscapularis.
Right.
In a revision setting, especially after a failed anatomic joint, the subscapularis is invariably compromised. It has been taken down and repaired multiple times. It is scarred, it is retracted, or it is entirely absent.
So we can restore forward elevation because we bypass the torn supraspinatus and recruit the massive deltoid muscle.
Yes, but restoring the fine, combined, coupled mechanics required for internal rotation behind the back without a functioning subscapularis remains a profound biomechanical impossibility with current implant designs.
Given that glenoid-sided failure is the leading complication in these revisions, and knowing that we are dealing with osteopenic, heavily cavitary bone, I have to ask a blunt question. Are we simply approaching a hard biological limit to what mechanical fixation can achieve? I mean, you can engineer the most perfect titanium screw with incredible thread pitch, but if the host bone is avascular and structurally destroyed, aren't we just relying on magical thinking to expect osseointegration?
That is a highly perceptive assessment, and it is the exact reality we face in the operating theater. We are absolutely brushing against the biological limits of mechanical fixation.
Because initial fixation isn't enough.
Exactly. Initial rigid fixation is purely a mechanical exercise. It relies on the pull-out strength of the screws and the compressive force of the base plate against the remaining cortical rim.
Right.
But long-term survivorship is entirely biological. It relies on living osteocytes crossing the gap and growing into the porous titanium coating of the base plate.
And if the bone is dead?
If the bone you are anchoring into is sclerotic, avascular, or structurally dead from previous cement thermal necrosis, no amount of clever engineering, locking caps, or divergent screw trajectories can compensate for that lack of biology.
It just won't heal.
Right. If the bone cannot remodel and integrate, the implant will inevitably fail via micromotion and aseptic loosening.
The fact that glenoid loosening accounts for the highest complication rate in revisions perfectly highlights the absolute Achilles heel of reverse shoulder arthroplasty, glenoid baseplate fixation.
It is the absolute foundation upon which the entire reconstruction rests.
Whether we are dealing with a complex primary osteoarthritis case with severe wear or a multi-stage revision scenario, managing glenoid bone loss is universally recognized as the single most critical factor determining long-term survivorship.
Yes. If you do not achieve absolute rigid baseplate fixation at time zero, the operation is a failure before the patient even leaves the recovery room.
If the glenoid baseplate micromoves by more than 150 microns under physiological load, fibrous tissue will form instead of bone, right?
Exactly, and catastrophic loosening is guaranteed. The current literature establishes that dealing with this is not a rare esoteric challenge. Significant glenoid bone loss is encountered in up to 40% of all primary reverse arthroplasties.
40%.
Yes. To manage this rationally and reproducibly, we must move away from eyeballing the defect and rely on modern, condition-specific classifications to guide our surgical tactics.
Because if you are looking at a 2D CT slice right now and trying to estimate the wear, you are likely missing the true pathology.
Oh, completely.
The two dominant classification systems we rely on are the Walsh classification for primary osteoarthritis and the Servo-Favard classification for cuff tear arthropathy. Let us break down exactly what these classifications are telling us about the specific mechanical challenges we face.
Right. The Walsh classification is absolutely essential for understanding the insidious progressive osteoarthritic wear pattern, particularly the posterior wear.
Right, the B-type glenoids.
Exactly. The modern modifications of this system heavily emphasize the B3 and C2 glenoids, and these are the absolute nightmares for baseplate fixation.
Why are they so difficult?
A B3 glenoid presents a dual threat. You have severe posterior retroversion, often exceeding 25 degrees, combined with profound posterior bone loss.
So the whole joint line is sloping backwards.
Yes. You are facing a surface that is essentially sloping sharply backwards, creating a massive paleoglenoid and neoglenoid articulation. Achieving stable, flush seating of a circular base plate on a severely angled slope without compromising the vault is incredibly difficult.
And what about the Servo-Favard classification?
The Servo-Favard classification, conversely, tracks an entirely different pathology. The wear associated with cuff tear arthropathy. This runs from E0 to E4.
And that tracks superior wear, right?
Yes, it maps the relentless superior and medial migration of the humeral head due to the lack of rotator cuff constraint. Over years, this progressively erodes the superior aspect of the glenoid vault,
Leaving it biconcave.
leaving a biconcave or entirely superiorly deficient structure where the dense subchondral bone necessary for your superior screws is completely gone.
Wow. So based on a recent critical analysis review published in 2025, the management strategies for these specific defects have evolved significantly. We are moving from crude biological solutions to highly engineered metallic implants.
We are.
Let us walk through the hierarchy of options, starting with eccentric reaming. This is generally deemed viable for minimal deformity, specifically when dealing with less than 15 degrees of retroversion.
Right.
However, the mechanical trade-off is severe joint line medialization. The literature calculates a precise mathematical cost. We lose approximately 1.6 degrees of external rotation for every single millimeter we medialize the joint line, alongside drastically altering our crucial soft tissue tensioning.
Yes, eccentric reaming is an exercise in surgical compromise.
Okay.
You are deliberately grinding away perfectly healthy, dense anterior bone to match the depth of the diseased posterior bone.
Just to get a flat surface.
Exactly, trying to create a flat, neutral surface for the base plate. While it provides a flat surface for immediate seating, the medialization you mentioned is highly detrimental. It profoundly slackens the remaining posterior rotator cuff, the infraspinatus and teres minor.
And that loss of resting tension directly causes that precipitous drop in external rotation.
It does, which severely impacts the patient's ability to perform activities of daily living. Furthermore, by bringing the joint line and the humerus closer to the scapula, you drastically increase the risk of the humeral polyethylene component impinging on the inferior scapular neck during adduction.
Ah, the dreaded stabular notching.
Exactly, which generates polyethylene wear debris and drives late osteolysis.
So moving up the ladder of complexity, when the defect is too large to ream away, we have the alternate scapular line, often referred to as the Frankel technique.
Right.
This involves deliberately abandoning anatomical version and tilting the base plate inferiorly to gain purchase deep within the dense cortical bone at the base of the scapular spine.
Yes.
But aren't we just kicking the can down the road by accepting a non-anatomic orientation? Doesn't that alter the vector of the deltoid force?
Well, it is a strategy of pragmatic survival. In cases of severe central or superior bone loss, the standard anatomical center line simply offers no purchase.
It's just air or mush.
Exactly. If you place your central peg there, it will hit cancellous mush, and your peripheral screws will bite into air. By angling the trajectory inferiorly, often 20 degrees or more, you are deliberately prioritizing rigid, immediate mechanical fixation over restoring perfect anatomical version.
So you accept the non-anatomic orientation.
You accept a non-anatomic orientation, and yes, it alters the deltoid wrapping, but it guarantees the base plate will not immediately fail under shear stress.
Yeah.
You are finding the best available bone in a devastated landscape.
Right. When altering the angle isn't enough, we step into the realm of structural augmentation, starting with biological bone grafting, most notably the bio-RSA technique.
Which has been very popular.
Very. But when evaluating graft sources to rebuild the vault, recent computed tomography assessed series demonstrate a stark, biologically driven contrast in incorporation rates.
The autograft versus allograft debate.
Exactly. Humeral head autograft achieves an exceptional 100% incorporation rate, whereas femoral head allograft trails significantly at just 66.7%. That is a massive failure rate for allograft.
And that difference is purely driven by cellular biology. An autograft, harvested directly from the patient's own resected humeral head during the procedure, provides living osteocytes.
Right. It's biologically active.
Yes, intact osteoinductive proteins like bone morphogenetic proteins and a perfect immunological match. It is biologically active. An allograft, which has been highly processed, irradiated, and frozen, acts merely as an osteoconductive scaffold.
It's basically dead structural architecture.
Exactly. It takes vastly longer for the host's vascular system to penetrate that dead bone, clear the necrotic debris, and remodel it with living bone.
And during that window.
During that prolonged, multi-month healing window, the allograft is slowly resorbing and losing structural integrity, which leaves the base plate vulnerable to micromotion and eventual aseptic loosening before the bone ever truly fuses. Using an allograft for a severe defect is like trying to spot weld a new chassis onto rusted iron. The weld itself might be strong, but the dead metal underneath is going to collapse before the bond ever truly matures.
But the true paradigm shift in managing bone loss, the intervention that is completely altering our surgical algorithms, is the explosive rise of augmented base plate.
Oh, without question.
Systematic reviews analyzing hundreds of primary reverse cases show that metallic augmented base plates, which are precisely milled with built-in wedges to fill the bony defects, have significantly lower overall complication rates compared to structural bone grafting.
The numbers are incredible.
They really are. We are looking at an astonishingly low, approximately 3.5% complication rate for augments versus 8.9% for structural grafting.
Right.
Revision rates are also dramatically lower, sitting at a mere 0.6% versus 2%. 2.4%. They effectively reduce notching and virtually eliminate early aseptic loosening.
To deeply understand why augmented base plates are vastly outperforming biological grafts, we need to discuss the specific biomechanics of the RSA angle, or base plate inclination.
Okay, let's break that down.
Correcting excessive superior inclination is paramount to survival. If a base plate is tilted upwards, which naturally happens when following a worn E2 or E3 glenoid, the repetitive vertical pull of the deltoid muscle creates immense shear forces across the bone implant interface.
And shear force is the enemy of osseointegration.
It literally slides the implant against the bone. By converting that angle to neutral or slight inferior tilt, we convert destructive shear forces into constructive compressive forces.
Right.
Augmented base plates with their predefined wedge geometries of 10, 15, or 30 degrees allow us to instantly dial in the perfect neutral or slightly inferior inclination.
So they correct the deformity while providing immediate rigid structural support made of solid titanium.
Exactly. There is no waiting for bone to heal, no risk of a biological graft resorbing over time, and no technical challenge in perfectly shaping a piece of harvested humeral head to match a complex multiplanar defect.
We even have robust data on custom, patient-specific 3D printed components, like the Vault Reconstruction System or ProMade implants. These are reserved for catastrophic, uncontained bone loss, where a standard augment simply cannot span the defect.
Right, the extreme salvage cases.
Exactly. These bespoke titanium implants show a phenomenal 96% osseointegration rate at midterm follow-up. However, we must acknowledge they carry a massive 29% overall complication rate in these extreme scenarios.
Well, those custom implants are absolute engineering marvels. They're essentially serving as the final definitive line of defense before we are forced to perform a total shoulder arthrodesis or a permanent resection arthroplasty, leaving the patient with a flail arm.
So the 29% complication rate is daunting, but
But it primarily reflects the devastating nature of the underlying pathology, not a failure of the custom implant itself.
that makes sense.
The soft tissues in those shoulders are often non-existent, heavily scarred, or previously compromised by chronic, low-grade indolent infections. The fact that we can achieve a 96% osseointegration rate in a vault that has been completely destroyed by previous surgeries is a testament to the porous titanium ingrowth surfaces we now utilize.
You know, using structural bone graft feels a bit like trying to rebuild a crumbling foundation using wet concrete while the house above is actively shifting in the wind.
That's a great way to put it.
In stark contrast, augmented base plates are like sliding a perfectly milled solid steel wedge directly into the defect, instantly stabilizing the entire structure. If augmented base plates are outperforming structural bone grafts so significantly in the published literature, both in raw complication rates and long-term survivorship, is there any remaining clinical justification for performing a biological bio-RSA in 2026 outside of strict hospital cost constraints?
That is exactly the debate dominating every major orthopedic forum today. From a purely biomechanical, immediate stability, and surgical reducibility standpoint, metallic augments are decisively winning the argument.
Right.
However, a contingent of highly respected surgeons still advocate for autograft bio-RSA, specifically in the younger 50-year-old patient demographic we discussed earlier.
Why? Just to build bone stock?
Yes, their argument is philosophical. We should strive to restore living bone stock for the future, fully anticipating that these young patients will inevitably require a revision in 15 years.
But the mechanical counterargument is incredibly strong, isn't it?
It is. If a metallic augmented base plate prevents the failure from occurring in the first place by providing vastly superior initial stability and optimal compressive forces, the need to build bone stock for a future revision becomes a moot point.
Right.
Why risk an early biological failure to prepare for a revision that a better mechanical implant might prevent entirely?
Exactly. But here is the catch. To perfectly execute the placement of an augmented base plate, or to accurately position a standard base plate along an alternate, inferiorly tilted center line, relying solely on traditional freehand technique and a generic drill guide, is increasingly viewed as completely inadequate.
The margin for error is simply too small now.
If you place a stepped augment just 5 degrees off its intended axis, you have entirely compromised the peripheral screw trajectories. This absolute requirement for sub-millimeter precision leads directly into our final segment, the massive explosion of 3D planning and intraoperative execution technology.
And we have rapidly transitioned from an era of experienced surgical estimation to an era of rigid computational precision.
They really have.
The baseline necessity of 3D preoperative planning is now undeniable. Current evidence confirms a terrifying statistic. Standard two-dimensional CT scans miss the point of greatest glenoid wear 52% of the time.
52%, that is unbelievable.
Think about that. If you are planning a complex reconstruction based on looking at a series of 2D axial slices on your clinic monitor, you are essentially operating half-blind. You cannot accurately judge the native version, the depth of the vault, or the optimal screw pathways.
Right.
3D planning software allows us to digitally extract the scapula, rotate it in 3 dimensions, and interact with the exact topography of the defect, mapping our base plate to the densest columns of subchondral bone.
And the accuracy of this software, when evaluated objectively, is remarkable. A 2022 systematic review evaluating 3D software concordance showed over 90% concordance with the preoperative plan regarding final glenosphere size.
It's brilliant.
Furthermore, it demonstrated exceptionally high matching rates for exact screw length and trajectory. Ultimately, the published series show that simply utilizing planning software leads to more robust, bicortical two-screw inferior fixation and longer average screw lengths.
And we know definitively from biomechanical studies that longer bicortical screws correlate directly with vastly improved baseplate stability and resistance to shear forces.
Right. Planning the perfect, mechanically optimal operation on a high-definition screen in your office is one thing. Executing that perfect plan in a bloody, tight, anatomically distorted surgical field is another challenge entirely.
It is night and day.
That is where the execution tools come in, and as a profession, we must evaluate them critically, not just adopt them blindly. Let us start with patient-specific instrumentation, or PSI.
Right.
These are custom 3D printed plastic drill guides designed to sit perfectly on the patient's unique native bony anatomy, guiding the initial central pin precisely to the planned computational trajectory.
And the mechanical benefits of PSI are highly measurable. It drastically improves version correction.
Especially in severe cases.
Yes. In cases of severe B3 retroversion, the literature shows that without PSI, experienced surgeons deviate from their preoperative plan by an average of 10.6 degrees.
And with PSI?
With PSI, that deviation drops to a highly acceptable 4.5 degrees. It also significantly reduces the risk of catastrophic suprascapular nerve injury from robe peripheral screws penetrating the sphenogonoid notch.
Right. However, we have a massive, glaring reality check in the current evidence regarding PSI.
We do.
Huge database studies, such as the widely cited Navarro series, show absolutely no reduction in the risk of aseptic revision at the 3-year mark when using PSI.
No reduction at all.
Even more concerning, and this is the statistic that stops surgeons in their tracks, the data indicates a potential 7.74 times increased odds of 90-day deep paraprosthetic infection when using these custom guides.
That specific infection statistic is deeply disturbing and requires immediate clinical analysis. Why on earth would a sterile piece of plastic increase a deep joint infection risk by nearly 8 times?
Right, it seems counterintuitive.
There are several mechanical and logistical reasons that are not immediately obvious. Firstly, PSI guides require intimate flush contact with the native bone to seat properly and provide accurate guidance.
So you have to clear away all the soft tissue.
Exactly. This often forces the surgeon to perform far more extensive soft tissue, stripping around the anterior and inferior glenoid rim than they normally would. This aggressive stripping devascularizes the bone flap and creates a larger postoperative dead space.
Which is the perfect breeding ground for a hematoma.
Yes, hematoma and subsequent bacterial colonization. Secondly, there's a significant learning curve. Struggling to seat a poorly fitting guide extends operative time, and we know that every additional 10 minutes of open wound time directly correlates with a compounded infection risk.
Right.
Finally, there are the logistical manufacturing lead times, which typically range from 2 to 6 weeks.
And what are patients doing during that delay?
Well, during that prolonged, painful delay, patients may be receiving preoperative corticosteroid joint injections to manage their debilitating pain. This further suppresses local immunity and drastically escalates the postoperative infection risk.
Beyond PSI, the industry is aggressively pushing computer-assisted navigation, or CAN, which uses optical trackers to guide the reamer in real time.
Right.
This undeniably improves inclination and version accuracy, but it adds significant surgical time for pin placement and registration. It also frequently increases the use of those far more expensive augmented components as the navigation software pushes the surgeon to correct even minor 2-degree mathematical deviations that they would have accepted freehand.
Yes, the software demands perfection.
Finally, we have the ultimate frontier, robotics, like the ROSA and MICO systems. Emerging cadaveric data clearly shows superior sub-millimeter accuracy for robotic milling, but the real-world clinical outcome superiority remains entirely unproven.
And this brings us to the crux of the digital debate in modern orthopedics. We are fiercely debating clinical versus radiographic outcomes.
Right.
We know definitively that intraoperative technology, whether it is navigation or a robotic arm, makes the postoperative radiograph look mathematically perfect. The base plate is flush, the screws are perfectly divergent, and the version is 0 degrees.
But does it matter to the patient?
Well, multiple high-quality recent studies, such as those by El-Sheikh and Gaj, show absolutely zero difference in final range of motion, postoperative visual analog pain scores, or patient-reported functional outcomes when compared to standard, freehand instrumentation executed by an experienced surgeon.
It feels like we are entering an era where we are treating the radiograph rather than the patient in front of us. We are spending vast amounts of healthcare resources, adding 30 minutes of operative time, and increasing infection risks just to correct a 3-degree version error that the patient functionally cannot perceive when they are lifting their arm.
Exactly.
Given the immense added financial cost to the hospital system, the significant manufacturing delays, the required radiation load for protocol CT scans, and the glaring lack of proven long-term functional superiority, at what point does intraoperative navigation or robotics become the true standard of care rather than just an incredibly expensive hospital marketing tool used to attract patients?
It becomes the standard of care only when it demonstrably prevents early revision surgery or significantly reduces major mechanical complications across a broad population over a 10-year horizon.
And we don't have that data.
We do not have that data yet. Currently, technology is absolutely invaluable for the severe deformity, the B3 or E3 glenoid, where native anatomical landmarks are completely obliterated.
Right, as a safety net.
Yes. In those extreme cases, navigation or PSI is a genuine game changer that prevents catastrophic misplacement. But for the routine primary case with mild concentric wear, the added cost, increased operative time, and very real potential infection risks currently outweigh the theoretical, unproven benefits of achieving mathematical radiographic perfection.
So let us synthesize the profound journey we have taken through the current evidence today. We are actively and perhaps aggressively pushing the reverse total shoulder arthroplasty into younger, far more demanding patients. While they achieve fantastic life-altering short-term functional gains, this demographic shift invariably leads to a higher rate of early complications and a looming, unavoidable wave of complex revisions.
Right.
When those revisions inevitably occur, managing the critical defining issue of glenoid bone loss, which is the primary culprit in mechanical failures, is paramount. In that highly challenging arena, metallic augmented base plates are increasingly proving their biomechanical superiority over structural bone grafts in providing immediate, reliable, compressive stability.
Absolutely.
Finally, while 3D computational planning is undeniably vital for understanding hidden anatomy, the execution technologies, whether it is PSI, navigation, or robotics, must justify their inherent surgical risks and immense financial costs with hard, long-term clinical survivorship data, not just pretty post-operative scans. If you found value in this expert discussion, please take a moment to rate and share Deep Dive Ortho with your colleagues to help us keep bringing you these deep clinical insights.
The evolution of this procedure over the last 30 years has been breathtaking, transforming from a desperate salvage operation for the frail to a highly engineered kinematic reconstruction for the active worker.
Right.
But as surgeons, we must remain grounded by the hard complication data and constantly vigilant about the physical boundaries of mechanical fixation in biological tissue.
Which leaves us with a provocative, forward-looking question to mull over as you head into your next clinic. We have spent this entire hour discussing how to perfectly machine, navigate, and position titanium and cross-linked polyethylene to reconstruct a diseased joint. But as we increasingly embed these rigid mechanical constructs into the high-demand environments of 40 and 50-year-old patients, the ultimate question is unavoidable. Will we eventually hit a hard biological ceiling on mechanical longevity, forcing our entire orthopedic field to execute a complete revolutionary pivot back towards biological joint resurfacing and advanced tissue engineering in the coming decade?